Oh, somebody's here already. All right, I guess we're live. Hi, everybody.
Hello.
All right, welcome back. James Gaor, Halcyon Health.
I'm Emilie Scott, Halcyon Health.
I'm Shea Suskin, also with Halcyon Health.
I know, it's kind of silly that I said that. It's pretty obvious. Well, welcome. So yeah, we have some fun things to talk about today in these COVID times. I don't know if you really call them fun, but hopefully something interesting and new. The reason that we keep bringing these out is really engaging you and hoping you bring us questions about anything on your mind. So starting off with, I can do a little screen share of some of the latest stats, which I know some of you are also following at home. Let me see. Oops, sorry. Okay. So let's make sure you guys are seeing the same thing I am in a second. And so here we are. So we can look at some of the basic stats. I don't know if Emilie, you wanted to run through them. I mean, they're pretty self-explanatory in terms of the overall absolute numbers. I guess the biggest thing that we always had wanted to keep an eye on was the trend. We talked about before, I think, the cases in general are a good marker, but not necessarily the most important thing. So how many cases are we seeing? New cases per day. And the trend, meaning, is it going up? Is it going down? We're expecting cases to continue to be seen, new cases every day. But as you're looking through this graph here, there's no big exponential leap, which is good. These are the number of cases that are being, or number of tests are being done per day. And I think a lot of what we always are looking for is the hospitalization rate. So once again, looking at this trend, there's these ups and downs, if you will. But looking at, ICU cases, total hospitalizations, it isn't necessarily going through the roof in any way. And yeah, that's pretty much it. And the mortality rate has been pretty steady. Sometimes we'll have 1, 2, sometimes I think yesterday they reported 4 new mortalities, but it isn't skyrocketing at this point from what we've seen. I don't know if you guys have any other insights into these numbers, but that's how we're kind of interpreting it as a whole.
And this was very local data. If you look at the state as a whole, what they've seen over the past week is a decline in deaths per day. So that's been a positive change that we've seen in the state of California. And that's been persisting over, I believe, a 7-day period, right? Where we've seen a decline in the death rate per day.
I believe so.
Which is a good sign. And also, I think the number of cases per day in the state of California have declined.
Okay.
So over the past week. So that's a trend that we've been wanting to see.
Yeah, so that's good. And yeah, so that's the overall updates. Looks like we're freezing according to some people. So hopefully that resolves itself. We're seeing ourselves okay, but maybe our internet is not the greatest. Audio's a little rough today, so let me see. Can you guys hear us?
They said it was better while you were talking. It sounded like it got better.
Okay.
No, but lots of buffering.
Okay, so sorry about that, guys. Hopefully we can change that. Yes. So going back to, I think, the case count, one of the things I was looking at too in terms of mortality rates was the percentage in skilled nursing facilities. So they're actually releasing that data more granularly at Orange County. So I think out of the 61 deaths, 11 of them were in skilled nursing facilities, which is quite a big percentage of that. So I think keeping that in mind in terms of mortality, where that's coming from, is a significant thing. So yeah, hopefully you guys keep us posted if the buffering is an issue. Hopefully it's not as much going on, but we'll keep on going and try to fix it as much as possible. So yeah, any other insights on the numbers?
Everybody's buffering.
Yeah.
Buffering. So let me see if I can adjust that in any way.
I don't know if it has to do with their internet connection as well.
I don't know. Hopefully not. Let me see if I can change anything.
In the meantime, I can keep talking.
Yes.
So the next thing we were going to talk about was the antibody testing, which we've continue to do. We've had 4 more positives come out of our antibody test. So that's 5 total now of the approximately 70 to 80 that we've done. All the people that have come out positive have had somewhat of a clear contact. Some people did have an illness without a clear exposure to someone with COVID. And so that's been interesting. Some travel histories were connected there to Washington, but not anything so clear. So it's been interesting to see some more positive tests come out. We're starting to send more tests to LabCorp and Quest now. Before we were really exclusively working with Genolite in San Diego because they were really first available. And now we've been working with Quest and LabCorp more, mostly honestly because it's more convenient. We're able to send those out daily. They have a courier that comes pick it up. Whereas with the lab in San Diego with Genolite, we were having to drive down there or ship everything all at once. The 2 labs are using slightly different methods in detection of the antibodies, both of which have been vetted in the past for this kind of testing. So there isn't, it's not like one is drastically better than the other as far as quality or accuracy goes. So that's why we've been comfortable using both of them somewhat interchangeably. It still goes to say that with the antibody test, we're still working on understanding external validation or use outside of the test in the real world because it's a brand new test and we don't know what it really works, how well it really works in the real world. We don't have the exact false positives, false negatives in real life. We have some sense that, it's with internal validation with the lab that these tests are very accurate from their validation. And let's see, I guess more questions about who we're opening this up to. We have more capacity now to test people for antibodies. So if people want to come do it, they're welcome to. We are able to test with people in our practice. If you have friends or family you want to refer for that. But then you've got to ask, what's the utility of the test? Why do it? And what are you going to change by doing it? How are you going to change your behavior? And we've been telling everybody pretty clearly there's 3 questions that you should ask yourself about this antibody test. One is, will the test tell you if you're immune and safe? And the answer is no, it will not. So there's no place for this test to change your behavior. So we would be reckless to tell people, yes, come get an antibody test, and then based on that we can go ahead and we can clear you for work, or that doesn't make sense at this point. We don't have enough information to tell you that. The second question is, will this test tell you if you've been exposed to COVID? And the answer to that is maybe. It seems like that's the point of the test right now, is to see what is the true prevalence or how many people really have had this disease in our community. And we're hoping that we're getting accurate information, but again, not certain. So, most of the people that are coming, it's really for curiosity's sake. It's for interest for them. What I'd hate for it to do is give people a false sense of security. We have had people who have had positive antibodies, and then they are coming in and reaching out to Hoag to talk about donating their plasma. So that could be something that could be useful to come out of it, because I do think they are using the antibodies testing for that. So I've been talking a lot. Do you guys want to add anything about the antibody testing?
Yeah, I'll just summarize. I think the main take-home point is that the antibody testing, all of the antibody testing that's out there, none of it at this point is being used to change public policy or even employer practices. Meaning, there is no immunity card. I don't see one happening anytime in the near future in terms of, having this proof of immunity, like Emilie had already mentioned. It's not changing our recommendations, I should say, on social distancing, hygiene. So the day-to-day behaviors and even public policy, the antibody tests really are not guiding any change in that. So once again, just making it clear that people who do decide to get their antibodies checked are really doing it from a real personal curiosity perspective, and if that's helping your anxiety about whether or not you had it in the past, and once again, we're open to having that one-on-one discussion and making sure everybody really understands the meaning of the test, the limitations of the test, and also, like Emilie had pointed to, that the tests are accurate in terms of what they can see, but the more challenging concept is that if you don't have a lot of disease or prevalence in a community, the false positive rate can be high even with an accurate test. And so because of that, it is not something that we are using at this point in time to say, go to an employer and say, like, here's all your employees, these people have antibodies, they're all clear to work. That is not something that we are using the antibody tests for, and caution people to think about that moving forward.
Yeah, I'll just add, I think that was perfectly said, but I have heard from patients and from others in the area that there are, even though we're saying medically we're not really at that point and we don't recommend using antibody tests as a clearance or proof of immunity, I think there are some employers that maybe not explicitly, but that are, doing point of care tests on a large scale, and maybe there might start to be some pressure to take certain risks if you have one of those positive antibody tests. So I would just say, be cautious of those. The medical community, here in this country is not using them that way at this point. So talk to us about that if there's questions. And, like we've been saying, there's still a lot to be studied about these tests, but some of these point of care tests that are being used, it's possible that there could be a higher rate of false positives with them. And I have had a patient so far that had one of these at work that was positive a while ago, and then she wanted to just check it out because it didn't seem accurate to her, and had the Quest antibody testing, and that was negative. So we're seeing those scenarios. It's hard to know what to make of it. Talk to us about it if you're in that situation where you've had one of those point of care tests at work, and that might be a good reason, depending on what your clinical history is, to confirm it, with a serum test, with a blood test, or not.
And for clarity's sake, a point of care test is where they go and they stick your finger, and then they put it in this little plastic cartridge, and the results come back in 15 minutes. It almost looks like a pregnancy test. And we had talked about these earlier and opted not to pursue that in our practice because there's so many questions about the accuracy of these tests. So that's what Shea's talking about there.
Right. And then once again, just going back to it, just as the example that Shea had just mentioned, right? So if you have 100 employees in your company and you're using these tests, and even just one or two of them are falsely positive, that could mean some significant downstream effects if we're using these for clearing people to work. So we really just want to express, once again, caution in using these, and clearly people are thinking about it, are very proactive. And not to say that this won't play a role in the future, but as of today, once again, these are the things that we're facing, and hopefully in the future, maybe there's quantitative tests, right? Right now, all these tests, I'm telling people, these are very qualitative, meaning it's positive or negative. We don't know how many antibodies, what level of antibodies you have, because that takes a whole different testing procedure, that takes longer time. And also, even what level is beneficial or potentially beneficial. So once again, we're just very early on in this, and so just going very cautiously forward is our approach so far. Cool, awesome. So that's antibody testing. Unless there's anything else that you want to talk about, Shea.
Nope.
Oh, awesome. So so we were going to talk about also just changes in our workflow in the office. We had mentioned it in the newsletter. We had been open, so we never really shut down, right? So we did minimize things pretty aggressively, and everybody was appropriately cautious about wanting to come to the office because of everything that's been going on. But now we feel more comfortable now. We've had always been very cautious about our cleaning procedures and making sure everybody is appropriately distanced from each other and face masks. But once again, we just want to reiterate, we're open. So if you need to be seen or prefer to be seen in person versus virtual consults, we are making those accommodations. We've unfortunately had to take out our coffee machine and snacks, and no shared books in the waiting room, clearly because we want to minimize any spread of infection. So those things have changed in our office. We are changing our workflow so that, as many of you already experienced, you can come pull in the back, the parking lot area, and wait until your appointment time, and we can come meet you and escort you, or at least wave you into the office, just to make sure there's nobody there that you would interact with. So outside of that, we also ask that everybody wear a face mask. We're all wearing face masks in the office. And so we also kindly ask that you do as well. If you don't have one, we do have some that we can share with you when you come to the office. But those are the main things, pretty simple, that we've done to increase our infection control. And we're cleaning down every room with disinfectants after each use, and so forth.
Really, it's been just Nancy's working in the office still. Julie's been at home pretty much this whole time. We miss seeing her. But Nancy's been in the office, and James and Shea and I have been taking turns there. Heather, the chiropractor we work with, is still there occasionally seeing patients. So we're careful about who comes through the office. Nancy and I have been talking, and all of us have been talking about temperature checks and what is the meaning of that. And, we can talk about that in a bigger way. As far as your safety with dealing with us, the one thing that you have with us is that we know you guys well as our patients, and we also know our staff really well. So we have been very clear with Nancy that if she's not feeling well, she should not be coming to work. And to a lot of times this can become infectious without having a fever. So if checking a temperature is the only thing we're doing, I don't feel like that's enough for us for our workflow. So there is a degree of trust that goes with this process with our office, and I feel really confident, and that's something that we've worked so hard to build: trust with you guys, trust with our staff, trust with each other. And so I feel really good about that and confident that we can keep you guys safe. And of course, we're trying to do what we can on the phone. So for example, if we want to do your annual check-in, what we'll do is we'll talk on the phone for a while first to minimize the time we spend face-to-face, and then have you come in and do a skin check or a physical or a blood pressure check in the office. And if you prefer to do things in the car, and if it's easy to do things in the car, we might choose to do that. So there's a lot of flexibility here, meeting people's comfort levels and minimizing exposure. So, yeah.
Great. So yeah, that's pretty much it. I think, once again, we're happy to see everybody. Logan had asked some disagreement over the data surrounding death rate, especially when people argue their views on whether or not it's time to reopen things. What data sources do you rely on or recommend? So great question. I think one of the things, the numbers we've looked at are the Orange County Public Health data, as well as the state's data. In fact, I think the state's data is more up to date because the hospitals, I believe, have to report everything to the states in a certain time frame, and I could be mistaken on this, so please correct me if I'm wrong, versus the county level, which is really interesting. So supposedly I think the state is most up to date and recent. So in terms of looking mortality rate, that is one way of looking at it, and so that's why supposedly the governor's office is more up to date in terms of the numbers rather than the county level. But once again, please correct me if I'm wrong. I'm not quite aware of the details on that. So that's those are the data sources we look at locally. There's a lot of models out there, and we had a brief conversation, Shea and Emilie, about the IHME, and there's all of these models trying to figure out and project the deaths, hospitalizations, ICU, and how accurate they are and how limiting they are. And I agree with all of the above statements that they have limitations. There's a lot of assumptions built into these models that have various levels of error in it. So once again, they're models for a reason, meaning it's not exactly how it's going to turn out. So once again, I would always be very cautious about interpreting them as that's exactly what's going to happen. They're projections, and they vary based on the sources. So I at this point, I can't recommend any specific model over the other. Once again, they're all out there. I haven't done my due diligence in really vetting a specific model over the other, but I will say that they all have their limitations, and that we should always understand what the assumptions are built into it before kind of following that.
Yeah. And I think if you look at any sort of statistic, people can take a statistic and put a lens on it and make their argument. So people will take data in different places and talk about it in different ways. And maybe that's kind of what you're referring to, Logan. It's so tricky when people's voices are so loud and so passionate, and there's so much that's uncertain. So quite honestly, Logan, we don't have some magic clear reliance on one data source that we feel is the most accurate per se. It's looking at all of these things together and getting a sense of what's happening locally by looking at our hospitals and all of that. So
I think maybe just to mention too, one like specific example of how that lens on how you interpret statistical data can come into play, and what we're seeing there's a lot of controversy about this right now, and maybe this is also what you were referring to, Logan, is more than the death rate, the actual case fatality rate, and that's being hotly debated right now because that's dependent on how many cases there are, which we know that we just don't have a good handle on that. We started testing pretty late, trying to use these antibody tests that we've talked at length about the limitations of these antibody tests, but trying to use these antibody tests to then look backwards in time and predict how many people are likely to have been affected, and then use the death rate. The death rate, I think, can be pretty objective. We know how many people are dying, and I agree that the public health departments and this at the state level can be a good source of that. I mean, even in that, there is some concern that that deaths due to COVID are being underreported. People that die at home, or many people that are sick with COVID have many other comorbidities, and so what exactly is the death getting attributed to? So the general thought among the medical community is that overall deaths are underreported due to COVID. But yeah, so there's a lot of controversy about this case fatality rate, and again, the kind of lens you bring to it can really come into play there on how you interpret that and how we're all kind of estimating how many cases there have been at this point. So that's something that's important to understand too.
I'll piggyback on that. So case fatality rate, like Shea had mentioned, is really the rate of deaths among the people who are confirmed positive. There's another one called infection fatality rate, which is the death out of everybody who's presumed to be infected. So that takes into account the estimated prevalence of disease, which, as we've discussed at length, is very challenging. It's a guess at this point. It's an educated guess, but it's still a guess versus confirmed cases. So when you extrapolate that, so the infection fatality rate is lower because it's out of a larger pool of people who have had the disease and never got tested, and just got sick and got over it. And so those are different numbers, and so people will use them interchangeably, and in terms of fatality rates. So once again, as Emilie was alluding to, it's very confusing and challenging to get numbers and to use them in a truthful way. And in the most accurate way possible. And it's not people are necessarily being malicious about it, but once again, it's very complicated, so it's easy to get missteps in terms of taking the data, and it's a matter of a decimal point difference based on what you're using sometimes. So once again, just to clarify that, I think in terms of fatality rates and what's being thrown out there. But yeah, that's it for data, I think.
Thank you.
Yeah, cool. So beach. Should we go to the beach? Or not? So yeah, reopening. That this is part of the previous question about disagreements about numbers, and what numbers should we use to help determine whether or not we can reopen or not. And we kind of discussed this before. It's happening, right? And it should happen to some extent in terms of moving on with our lives and trying to figure out how to do it in a safe and effective way as possible. The numbers in California have been at a place where it seems like we have the resources, and we talked about this before, resources to handle targeted reopening in very different ways and different ways of operating than before. So I guess, the beaches is we talked about in terms of going outside and getting fresh air for our mental health. We talked about this earlier today. Seems like a nice thing that everybody wants. What are your thoughts on how we do that safely? And should we all go to the beach at once? I guess.
Let's go. Let's all go together.
Yeah.
Shea?
I mean, I think James and I had a good conversation about this yesterday. I think like the one-liner big picture is this is just such an important time for us all to be looking out for each other and taking care of each other. It's been hard in these last couple of weeks to kind of, as everyone's getting so restless and as the implications of this lockdown economically and mentally and all of that are getting much harder. It's starting to get pretty ugly out there and polarized, and it's going to be tricky to muddle our way forward in all of this. So I just think the more that we can try to see the humanity in each other and, understand that all of us, as we start to open back up, we're going to be taking risks. We need to take calculated risks. That's going to look a little different for everybody. But yeah, I mean, I am all about fresh air and being out in nature. And I think you can do that in a safe way. I think you can do that, looking out for your neighbor. And if you're in a crowded place, bring your mask along and wear it to protect the people around you. To protect yourself, you need to be conscious of where your hands are and wash your hands after you touch public things and not touch your face. These basic things, I think we all can do that. And that doesn't mean, we should snap our fingers and everything should open back up tomorrow. But as we press forward, if we can just keep it in mind to look out for each other, I think that's what we need to be doing right now.
The beach controversy is a interesting. I feel like there's a lot of symbolism there in many ways, and when you start to look practically at what's happening at the beach, I think. If you were to make a decision when they open the beaches, if you were to make a decision, is it safe to go there? I think you have to use your common sense. So if you go to the beach and you can't stay 6 feet away from the family next to you, then maybe that's not the right place for you to be. If you can go to the beach and there is, a good 20 feet between you and everyone else, and the sun's out and the wind's blowing, and then it seems like it's a pretty low risk situation. So. So that all depends on so many things. If everybody's going at once, then it could be problematic. If there's space and people are, like Shea's saying, if we're being thoughtful and respectful and get there and have to turn around and come home because it doesn't feel safe, then I think that's kind of has to be an individual assessment and decision. I don't know.
Yeah, I agree, and I think one of the things that helps tries to make it a safer thing to do is the fact that really, if you do go to the beach, it's not for what they're calling passive activities. We kind of joke about that, right?
Right.
The notion of passive activities seems like a contradiction. But anyways, you can't really, some certain places that are opening up, one of their rules is you can't just sit around and lounge. So, you can run, you can walk, you can surf, you can swim, but you can't just lay out. And that, the intent behind that is clearly to prevent people from congregating and having increased risk of being too close to each other. And once again, as Emilie talked about, part of this, and we talked about this, Shea, is really built on social trust, right? So having this conversation openly with ourselves, with friends and family, this is about trust building, right? This is like one of those really cheesy trust building exercises where we fall and someone's going to catch you. So that's the way I see this as going to the beach, right? This is a trust exercise, and as we move forward, this is what we have to try and do, and that's the positive spin on this is, it's really simple, right? And so I was going to talk about this later, but really the things we've learned over the last 100 years, we've gone from, horses and buggies to, people going and trying to live on Mars and the internet and all this stuff. But in all of this time, the things that we're doing right now is the same things. It's hand washing, it's, social distancing, it's face masks. And those are the tried and true things. And the parallels are pretty striking to me with preventative health, right? It's eating properly, it's getting your movement, it's getting good sleep, really core things that are really fundamentally the same when you look at the forest versus the trees. And so when we're talking about these things that are opening up and how do we move forward, if we could focus really on the basic concepts, like Shea was talking about, washing your hands, wearing masks, keeping distance, all of these things, then I think we can do these things in a safe way and trust each other that we're all in it together and that we're doing the right thing. So that's my perspective on opening up, moving forward, and clearly, businesses are going to operate differently in order to accommodate what I just talked about, right? So restaurants, as we already know, we can't sit together with our friends at the table anymore, but when restaurants open up, there's going to be some various ways of doing things, but I think, that's the new normal.
Right. So James had written here about checking temperatures. So I don't know if people have questions on that. It seems like a confusing thing to me. What good does that do? Shea, do you want to talk about that, or do you want me to talk about that a little?
Like in terms of
what is it?
like
what good does that do?
Patients that would come into our office?
No, they're talking about, like, if you're going to go back to work, to make the work environment safer, they're going to check everybody's temperature at the office. So
I mean, many large employers are doing that, and I think it's one of those things there where when you have 300 employees at at the hospital where I used to work, or more than that, and it's such a large scale of people, things like that maybe make a little more sense, because you have to standardize things. It's, it's one way to get some objective data, but it certainly has its limitations. And, that's why, as Emilie was talking about earlier, in a small business like ours, or in a, with a smaller scale, we can do things that that are more meaningful. I don't know, but I'm not sure if that's what you meant when you said checking temperatures. Like
the discussion that's
that kind of setting, or
I think that's what I was trying to get at. That's there's been, I've heard people question kind of, well, is that something that then we can feel so much safer? And I think there is a push and pull with that. It is, like Shea was saying, it's one more data point, but there also is still uncertainty, unfortunately. So I think that in a larger scale to do that, it makes sense, and maybe it can help screen some people through, but it's not, again, a perfect thing. So if you're working, or if you're in a work environment where you don't feel safe, or someone around you is coughing and sick and they don't have a fever, I still think that you should speak up, and you can talk to us if you need some support, or if you have any questions about the safety of your workplace, or if you're an employer and you have questions about how can I make sure that my workplace is safe. We're happy to talk about that with you guys too. So I just want to bring that up.
Yeah, and there's somebody that was asking, just have we been reviewing any city-specific reopening plans, and if so, any concerns that cities have missed by locals, municipalities, or overseen by the state? So the question basically is, if we've reviewed any of the reopening strategies, is there anything that should be changed? I've read probably the same things that some of you have read, so I don't have any inside scoop in terms of any specific plans. Once again, opening things up, so it's minimizing or eliminating any type of in-store or in-retail congregation, or definitely limiting the amount of people in an enclosed space is part of this reopening, which makes sense to me. Once again, going with the simple tenets of social distancing, face mask and hygiene, as long as you can operate in a way that supports those strategies, then I think those are reasonable things to do during this time. And so, yes, I think that's what I've reviewed briefly. I don't know if you guys have reviewed anything differently, but once again, going back to the previous statement, there's the facts that we know about what's happening. They're pretty few, right? I mean, there's a lot of things going. There's a ton of information out there about what could be and potential and this and that, but really the things we know to be, at least have more faith in knowing that seems to be closer to fact, are pretty small. So it really is the same as when we started this conversation weeks ago, and we're continuing to hammer the same points over and over again.
I think too, like we have to know, and again, people who are feeling fervor or very loud voices, which again I don't think is a bad thing, but we just have to be able to understand how to filter through everything. There will be loud voices as we open and the death rate does increase or there's more cases, but that's also to be expected too. That's part of this. And so everyone's going to interpret that in their own way and put their lens on it and make it one thing or another. But the reality is that this is part of this process. As we open it, it will spread more. And so we have to expect that a little bit, and we have to be able to understand what's our comfort with our individual risk. And we shouldn't judge each other for what we don't or do feel comfortable with. What I find, maybe we can give our family members some space. Like if someone's feeling more anxious about it than someone else, then that's okay. And let them feel like they can be isolated more. If that helps their mental health more to stay isolated and feel safer that way, then let's let them do that and not feel like we have to push them to reopen. If people are feeling like they're losing their minds, being cramped up, and they need to get out or else they're going to go crazy and they don't mind taking a risk and they want to go out there, then let's let those people go out in a safe way, in a responsible way, and let's keep watching to see what happens. I think again and again, we just have to keep respecting each other and knowing that we all can make our own individual risk assessment. So what about private tennis lessons for kids where they're on different sides of the courts from the instructor?
Trying to figure out risk levels of different things. That's a great question. You know, my initial, and I'm going to give a very primal response because why not? Is yes, I think. I mean, right? Like I could be wrong on this, but I think you're outdoors. There's minimal. Once again, it's not a contact thing. I mean, you're hitting the ball across the courts over long distances. You guys can feel free to disagree because I'm just kind of talking out loud. But that's my initial answer. Seems like that. I mean, you can run, you can do outdoor activities. Hitting a racket with a ball across a court seems pretty harmless to me. I guess I would personally be comfortable with that. Once again, going to your whole risk assessment thing.
Yeah.
I would feel comfortable playing tennis with a tennis instructor.
I think that depends for me, and I'll let Shea talk too, but we recently decided to bring James's parents back into our inner circle. We felt so confident with our practices at work that we're safe. We've really been isolated, and it's just really been for our kids' mental health help for them and for us and for everybody to reintegrate them into our lives. And so for me, knowing that, I've become way more uptight about everything else. So like knowing that my kids are going to go see my in-laws, I would not let them have tennis lessons right now because I'm just so uptight about protecting them. But if we weren't bringing the in-laws into the fold, then maybe I'd be more comfortable with that. Like James is saying, it does seem relatively low risk. And maybe I'm just being extra uptight, but I really don't want to hurt my in-laws.
That's fair. And Fred brings up a good point. Clearly, if you touch the tennis ball and there's coronavirus all over the tennis ball and you touch your face, clearly that would not be good.
Right.
Once again, the risk level of that is something that I don't have any answers to, but clearly to be on the more cautious side, it would be reasonable to avoid those types of
yeah, and if the tennis instructor is coughing all over the place,
yeah,
I mean, there's a level of trust with the person that you're connecting to also.
Yeah.
So, yeah. I don't know, Shea, if you want to...
I think both of what you guys just said just perfectly illustrates my gut response too was, that seems pretty harmless. There's a slight increased risk there, and what Fred said, illustrates that perfectly. Yeah, you could, touch the racket or touch the ball or touch something the coach is touching. There's a slight increased risk there. But if you're aware of that risk and you're calculating that risk, and exactly like Emilie said, it also, part of that equation is who you're going back home to, who's in your inner circle that you're interacting with. But I mean, it's a good question, and we're all going to be dealing with a million, micro level questions like that. So I think those are some of the big picture things to consider. Like Emilie said, how well do you trust the person you're opening your circle to? What exactly are going to be the, potential risks in interacting with that person? And then who are you coming back home to, and what's their health profile and their risk factors? So those are some big picture things to think about. But
I mean, if we see like 0 deaths and 0 case counts across the U.S. and California for 2 weeks, then we can have a very different conversation about this. But that's not the reality, and it probably won't be for a while.
And on that note, too, question by Caroline, basically asking about contact sports, right? Are they off the table for quite some time? My answer is yes.
Definitely a higher risk.
Yeah, I mean, it's unfortunately, that one is higher risk, right? So in a time when we start opening things up, I think contact sports are going to be off the table until there's a sense of herd immunity and or vaccinations.
If herd immunity can even happen.
If herd immunity is possible, too. Right? So we can talk about that a little bit. We don't know if herd immunity is possible in a meaningful way. So once again, there's just a lot of unknowns, and because of that, I would have to say contact sport is something not happening in the near term, unless you guys see anything different.
No, it's so tough. Yeah,
it may be nice too. But
I mean, it's like if you have 3 people and they all know each other. I mean, it's kind of like what's your inner circle, and how much are you going to open it, and what kind of level of trust do you have? As far as like an official open up contact sports across, the state of California, or some large implication of that, I don't see that happening.
Even on a small, right? Like even like in the city or county league. I mean, that's to me a high risk
for sure. But like if you want to go play football with your cousin, and your cousin and they're part of your inner circle.
Okay.
I don't.
Once again, there's risks associated with that, and just thinking about that deliberately, and who are they contacting with? Are they doing the same thing with their friends that we don't know about? So it's it's a slippery slope that we have to be mindful of.
I guess contact sports is just the same as making out. No, I'm just kidding. Oh, God.
What I was just going to say about that, and then I think Fred brought it up also, pro sports, my understanding, and I'm not a huge sports fan, but my understanding is that most of the pro sports are talking about starting back up even in the summer or the fall, but taking a lot of precautions. Pro sports have the resources to be keeping a very close eye on their players, with temperature checks, and then everything on up with how they're going to be, monitoring the symptoms of players. They're not talking about having any fans anytime soon. But, that's a risk that is, that's a calculated risk that they're talking about doing. And I think it's likely that on the pro level, contact sports will resume in the next few months.
And that's a good point. It's about resources, right? And so probably on the local level, it's probably once again, not impossible, but maybe challenging to have the resources to be as diligent about contact tracing and testing aggressively as the NBA or the NHL in terms of their budget and ability to mount those resources. So. And once again, this isn't forever, and I have by no means do I have a timeline when people can start doing contact sports. I don't mean to pretend like I know that, but in the short term, it doesn't seem like that would be something that I would expect in the short term.
But when you talk about resources, I mean, what does that mean? It's like testing and
sure.
Like if my sister is talking about roller derby, and if your team members and nobody's sick and everyone's been tested and you have access to testing, then how is that different than what they're doing in pro sports, I guess? I don't know. It's a good question. It's a debatable thing, that's for sure. I don't know. Yeah. Like, what resources are there? My understanding, and you guys could tell me, didn't they close all school sports for the next till 2022? Someone told me that.
I don't know about that.
Okay, that
I did not hear about that.
I'm talking rumors. I shouldn't.
I didn't know about that.
My kids aren't at that level yet, so I don't know. I'm not tuned into that.
There were some questions I should catch up with here. I think there was a question about viruses and long-term implications. Viruses have pretty broad range of symptoms. Impacts, do you have any concerns? Might be consequences of COVID infection that might be long-lasting, like herpes, HPV. As far as we know, no. I mean, there's some weird neurologic things certain people are experiencing. Once again, I'm not going to pretend like this is going to apply to large scale, but there's some neurologic things. But in terms of long-term sequelae or consequences, once again, it's so early that you literally think about the time scale of how long we've known this virus. I think it's too early to say that we know any long-term consequences. Is it possible? Sure, but once again, far too early for me to speculate, and would probably cause more anxiety to say that yes, it is, but I don't know.
I think what you more see is
from what we've seen so far. It seems like. I'm sorry, I was just going to say quickly. From what we've seen so far in the 5 or maybe if you stretch 6 months that we've known about this virus, it seems like people that recover it's a full recovery and we're not seeing, long-term sequelae other than complications of being hospitalized for as long as they have been and being on a ventilator and things like that are related to the treatment or the hospitalization, but not necessarily to the virus. So
right, that's what I was going to say, is that you really are only seeing when people are in, they're on a ventilator or on ECMO, which is like, this external pumping oxygen into your blood. And they could have kidney problems that persist after that. They could have ongoing lung problems that persist after that. But that's kind of that's someone who's quite sick and is the rare case with this. Fortunately.
Right. So there are those cases, and they're incredibly devastating and sad cases.
Yeah.
But as a whole, once again, we look at this from the forest to the trees perspective. They're relatively small percentages at this time, and so you focus on that in terms of once again risk and the statistics behind that. Somebody had asked, what was I going to? Oh, something about herd immunity. Why no herd immunity possible? I didn't mean to say it wasn't possible. I just think that the statement should be it's not guaranteed, right? So we don't know what immunity looks like and if it's long-lasting and how long it lasts for. So that doesn't mean that herd immunity is not possible. It's just, once again, I don't know what that looks like, when that is. Is it because of vaccinations? Is it because when we flatten this curve, over a period of the next 12 to 18 months, 70% of us will have been exposed to this in some form or another. There are questions that I have no answers to, and so once again, just kind of keeping that open so that we're not fixated on this is going to happen necessarily, but it's an assumption.
I wonder, do you guys know, when I think about this, and I'm going to probably say the wrong thing here again, but when you think about what herd immunity is, my understanding is that means that enough people, and it has to be like, I think there's a threshold of 60
to 70. Yeah.
Okay, percent of people have to have had exposure so that it doesn't pass through the community. And my feeling, and again, who knows anything, but I wonder with this coronavirus or COVID, that it's like this very severe thing because none of us have seen it, and then it turns into a milder thing, but it's not like it's gone forever. It's just not this frightening thing. So that's why, is that still herd immunity, or is that because now we have some immunity, but yet it's not full? Anyway, I'm pontificating, but the point would be, like, I don't know if it's going to be this classic, like, polio is gone and eradicated, or measles, we have herd immunity, and so nobody gets it. I don't know if it's going to look like that, or more like now our death rate and ventilator need has gone down and people are getting colds. And I don't know if that makes sense. Am I making sense?
Yeah, I think so. I mean, the fact is...
That was a lot of pontificating.
Yeah, no, that's it. Yeah, I mean, this is a new virus that nobody's seen.
We're just not sure, yeah.
Yeah, and that goes back to the unknown. And, and so the severity of cases are really from a majority of this modulated immune response where bodies overreact to the virus in a way that's really bad for the body, and people get sick because of that. So, that's the question, is over time, will our immune systems as a whole be more tolerant to this virus? That's a great question that we hope would be the case, I guess, is the best way we could look at it.
Which is a different conversation than herd immunity, for what it's worth. Whoever, I think it was Julie that was asking, or Julia.
Yeah. So once again, that's, there's a lot of ifs about this, and going back to what we know is we are doing all of this, we're reopening, we're being very cautious about minimizing huge spikes in cases and hospital resources so that we can all, in general, return to some semblance of our lives, clearly in a different way, but that's the whole goal, is keeping track of that.
Right. And Fred, that's a lot of zeros. Fred's putting in how many people would have to be exposed to get herd immunity. Right. And yes, you're right, Fred, by definition of it, it is. It's how many people in the community have it that don't need to be, so that we don't spread the disease. And again, I don't know if that's going to happen. This may mutate and spread into different things and become less dangerous. So we may never have herd immunity, but we might be safer. Right.
So lots of ifs. So just focusing on today, where we're at, understanding what we can do and control, and there's lots of things we can do and control and be safe. So I want to focus on, the positives, and that's what we're doing, why we're doing things, and why we can go to grocery stores, and why we can get takeout, why we can support our local small businesses, because we can still do these things in a very safe and meaningful way. And it's important we always keep that in mind, so that once again, as we move forward, we can continue to do it safely. There's another question from Julie about younger people having strokes related to COVID. That is interesting. I've read about that. Have you guys read about, embolic syndromes with blood clotting? Yeah.
Because I'm not in the hospital setting, but I've come across those articles too. I was just talking with my husband about this last week, who is more in touch on the inpatient side, and we think it's not a bad idea to maybe take the baby aspirin. It does seem like there's more and more data coming out that like James was saying, there's some sort of thromboembolic clotting problem with this. So, I mean, that's not a hard and fast recommendation. Everybody start taking baby aspirin. I think we don't know enough yet, but it's, if you're not high risk to do that for other reasons, if you're not at high risk of bleeding disorders or taking other blood thinner medications, or, there's a lot of ifs there. But it might not be it might not be a bad idea. If also, again, if you're in a high risk setting that you think, it's more likely you would be exposed to COVID, maybe healthcare workers. It's worth talking about.
Knowing I haven't read anything about this, that makes me the tiniest bit anxious. I tend to be very careful with medications for prevention. Just knowing that there is a certain number of people that will guaranteed, if in mass everybody started taking aspirin, I can guarantee you there are a certain number of people that would be harmed from the aspirin itself, from bleeding, from stomach issues, from all kinds of things that can happen with unintended consequences. So I think I would be hesitant to do that at this point. I need to read more. I think I would be cautious about taking aspirin right now until I know more.
I would also agree. I think it needs to be studied more in terms of mass recommendations. And once again, we always encourage the individual conversations because everybody has different risks and that we need to discuss. There have, once again, part of the hospital protocol, and correct me if I'm wrong with your discussion, is basically for people to be on blood thinners who are hospitalized with COVID, to help prevent those complications of stroke and clotting disorders. So that's part of it, and that's different, once again, from outpatient, us setting, where we start recommending everybody take blood thinners. That is not something that is recommended at this time. And once again, on a one-on-one conversation, if you develop COVID and are otherwise fine, that question of should you be taking baby aspirin while you're recovering from COVID is an interesting question that we would have a one-on-one conversation and go deeper into the data. And maybe there isn't enough data, to be honest, to really say one way or the other, but really understand what your risk is and your tolerance for that. But the risk benefits.
Even when you look at when we are trying to figure out if people should take a baby aspirin to prevent heart attack, stroke, or colon cancer, which all of these things aspirin can help with, there's a pretty clear guideline about how many people shouldn't do that. Even there's a certain degree of risk that you can have for all of those things, and still the risk of aspirin outweighs the benefit. So there's this sort of perception that it's this harmless thing, and relative to things it is, but I think we can't just blanket this for everybody. We have to be careful. So anyway, yeah,
agreed.
Thank you guys. Yeah.
Another question about COVID in children and Kawasaki disease. Once again, I've read those case studies. There's a subset of children who have some vascular phenomenon. So Kawasaki disease is inflammation in arteries, basically, that cause all of these long-term consequences, like aneurysms, etc. So I don't know a specific, there isn't definitive kind of information that I know of. I know that is definitely looked into, so I have not done my research onto specifically how that correlation, how strong that is, and I know that those cases are being reported, and it's interesting, and this being some vascular neurologic kind of thing that's happening with COVID is really interesting. And once again, going back to her statement earlier about is this because this is the first time we've seen it, that's why we're having these certain consequences versus, if we have some immunity, it won't be like this in the future. I don't know. I don't know, Shea, if you have any particular insight into that.
No, I haven't come across that at all, so I can't speak to that.
Yeah, there's been some case studies, but once again,
way.
I don't know too much more on top of that. And then we have
I threw up there, I'll just say, I threw up there a link Anusha asked about, and we talked about this a little bit at the end last week, like meetup groups, what's a way I can stay social right now while being inside. So I just, meetup.com has an Orange County chapter, and just glancing at the page there, they've got a ton of different like book clubs, a lot going on there, and there's a big banner at the top of the page that says everyone's doing online meetups right now. So I put the link up. That might be a good place to start in checking that out in case you didn't see that in the comments.
Awesome. Cool.
Yeah. James has to say this because this is, I would love for you to talk about this. We only have 3 minutes. Yeah,
there was a just really interesting article in the Associated Press today or yesterday, I think, just the parallels between now and the 1918 flu. And the upshot is basically, and I mentioned this earlier, not really much has changed in terms of the medical perspective and the public health kind of approach to things, except for the fact that at that time, their form of media and way of kind of communicating with the public was a little bit different. So there's a lot more like jingles, if you will. And so there's one jingle said, "Obey the laws and wear the gauze. Protect your jaws from septic paws." So I think we might close on that, because I think from 1918, the advice that they had, and I think history. I never appreciated history as a kid. I just was looking for the answers in the textbook, so I got a good grade, which, I regret. But
got you this far.
Yeah, it got me this far, but I think there's a lot of things I could have learned. But anyways, I really do appreciate history in a more meaningful way now, and I think history does repeat itself, and we're repeating the past in lots of ways, so we have an opportunity to learn from that, and so they dealt with this in actually a very similar way, and we're kind of following the footsteps. So hopefully we can listen to those past lessons.
And then Jan is saying he's heading out to walk the shores of the beaches where local plans have been approved by state, and making reasonable adjustments for my own risk score level. So that sounds like great advice.
There you go.
Take it all in.
Enjoy the sun. Enjoy the sunny weather safely, and
right.
I guess until next time we will say goodbye.
Bye.
Take care.